I'm virtually here today to present on our multi-centre experience in Australia of a small aperture intraocular lens in cataract patients. I'd like to acknowledge my co-authors and highlight my financial disclosure as a consultant to AcuFocus, makers of the ICA IOL I'll be talking about today. The IC8 is a hydrophobic aspheric monofocal acrylic IOL, which has a familiar pinhole mask with a 1.36mm aperture designed to provide increased depth of focus. Our study was a retrospective review of 126 consecutive IC8 surgeries performed by 6 Australian surgeons. All patients had cataract in at least one eye and a desire for a moderate degree of spectacle independence. Exclusions included visual axis scarring, and with surgeon experience in using the IC8, a recommendation to exclude mesopic pupils greater than 6mm. Uncorrected visual acuity at distance, intermediate and near, and patient satisfaction were assessed. As shown in our published paper in Eye last year, the modulation transfer function of the IC8 IOL is excellent. With an extended range of focus of over more than 2.5 diopters, as compared with a typical monofocal IOL of around 1/2 to 3/4 of a diopter. The IC8 IOL therefore delivers a true extended depth of focus from near to far, with tolerance of up to 1.5 diopters of astigmatism, and an IOL forgiving of refractive aim misses. All patients received an IC8 typically in the non-dominant eye and typically targeting minus 0.75 diopters spherical equivalent, with the fellow eye managed in a variety of ways, typically targeting emetropia. Patients achieved 20/30 on average for all distances monocularly in the IC8 eye, with intermediate visual acuity best, followed by distance and then near. More than 90% of patients obtained better than 20/40 vision at all distances monocularly in the IC8 eyes. But more importantly, binocular uncorrected vision revealed 98% of patients achieved uncorrected distance vision of 20/30. And 94% uncorrected intermediate vision of 20/40 and 91% uncorrected near vision of 20/40 or better. Patient satisfaction at both distance and near was excellent, with 84% of patients happy to recommend the IOL. Dysphotopsias were few, such as glare or halos, and typically patients adapt well to these in the first 3 to 6 months postoperatively. The group consensus was, though, that looking at mesopic pupil size was important to try and minimise these dysphotopsias, generally excluding those patients with a mesopic pupil greater than 6mm. Aside from routine cases, our series also included a variety of more specific indications where an IC8 IOL can be helpful. These include eccentric corneal scarring and trauma, prior refractive surgery, keratoconus, and irregular corneas. Again, the IC8 performing well and also in eyes with other ocular comorbidities. The only other comment in postoperative management is that YAG laser posterior capsulotomy treatment often requires to be performed around the mask of the IOL. In conclusion, the IC8 IOL is novel, tolerant, and forgiving. It utilises novel, small aperture optics to deliver an effective, extended depth of focus and functional spectacle independence in more than 50% of patients, increasing to more than 90% when just spectacle-free intermediate and distance vision is required in everyday situations. It's tolerant of astigmatism, corneal irregularity, and tear film disturbance, as well as forgiving of refractive aim errors. In addition to enhancing patient acceptance of monovision, it has a variety of more specific niche indications where the IC8 might be considered even as a first choice IOL. Thank you for your attention.